If you could kindly take your seats. This is Thematic Session 1B. We'll be starting in about 1 minute. Thank you very much. So you're visible. So if you see this, this means two. So I think that like with just, there's been like a shop life and someone took some of my cards, so we just do that. Thank you. Thank you very much. We're going to get started now. Very good morning. My name is Julie Goslaw. I'm with the International Food Policy Research Institute. And today we welcome you to Thematic Session 1B, Multi-Sectoral Approaches to Improving Maternal and Child Nutrition. It's my pleasure to introduce our two session chairs. First, I'd like to introduce Fong Nguyen. She's a senior research fellow in the Nutrition, Diets, and Health Unit, whose research interests are in maternal and child health and nutrition. She plays a significant role in the measurement, learning, and evaluation of Alive and Thrive, a multi-year initiative promoting optimal infant and young child feeding practices. In addition, Fong led the evaluation efforts for maternal nutrition interventions and is a team leader of the data and evidence to support policy implementation component for Poshan 2. She's also deeply engaged in assessing the role of food environments in adolescent nutrition. Fong has conducted research in Bangladesh, Burkina Faso, Ethiopia, Ghana, India, and Vietnam using various methodologies, including cluster randomized impact evaluation, mixed method, process evaluation, and costing research. Our other session chair is Abner Daniel. He's currently working as Health and Nutrition Manager at UNICEF Sri Lanka Country Office. He's a medical doctor and has completed his post-graduation in preventive and social medicine from Mumbai. His main areas of work have been around maternal and child health and nutrition. Prior, he has worked across different states in India in the areas of policy formulation, program design, and implementation, advocacy, knowledge management, formulation to delivery of results, and partnerships building for improved outcomes on maternal and child health and nutrition. Thank you very much. Please give them a round, warm applause.
Hello? Can you hear? Okay, thank you for the introduction, Julie. It's a great honor for me and Abner to be a co-chair of section today. We will hear a very fascinating presentation and insight related to maternal and child nutrition, how we can improve that through various approach and innovating from different people in the world. Before we deep dive into the presentation, it's all of us know that it's very important to acknowledge the role of maternal and child nutrition. Maternal nutrition always a topic of very hot and critical because it can impact not only the mother and the woman, but also the child and the future generation and the economic of the country. So it makes maternal nutrition is very critical for intervention. However, we all know that not only any of sector can be alone can improve that. It need to be multi-sectoral. It need to be the correlation of from different one. That just example in many parts of the world, poverty, lack of education, inequality or limited access to healthcare are all the barrier. So given that context, we have 5 presentations today that each of them touch in some important point to try to address like how we can enhance system, how we can improve the knowledge, how we can empower the community that can all together to improve the maternal and child nutrition. So we look forward for the presentation and the discussion.
Thanks. So like without further ado, let's invite the presentations. The first presentation is by Aklima Parveen. She's a senior project manager at International Food Policy Research Institute. And she's going to present on connecting the dots between agriculture, nutrition and health to improve nutrition-sensitive agriculture, a government-led randomized control trial in rural Bangladesh. So Aklima, your 8 minutes start now.
Am I audible? Good morning, everyone. It's my pleasure to present connecting the dots between agriculture, nutrition, and health to improve nutrition-sensitive agriculture, a government-led randomized control trial in Bangladesh. I would like to acknowledge my other researchers, authors, and co-authors who are engaged with this research. How did Angel come about? Based on IFPRI's Bangladesh Integrated Survey data analysis, we found that there is a link between agricultural diversity, dietary diversity, and women's empowerment. IFPRI designed agriculture nutrition gender linkage project, and the objective was to identify action and investment in agriculture that actually led to agricultural development, improved nutrition, and women's empowerment. So to rigorously evaluate impacts, IFPRI designed randomized control trial implemented in 16 sub-districts, and it tested 4 treatment arm N, so which included nutrition, behavior change communication, treatment arm A, which included agricultural production, and TAN, actually combining agricultural production and nutrition BCC, and the final one that brings agricultural production, nutrition BCC, and gender sensitization. So our Angel training package was developed with various ministries as well as Helen Keller International in consultation with IFPRI. The agriculture module has a stronger emphasis on homestead production and also the production practices of high value crops and non-crops and other content you can see here. The nutrition content focused on infant and young child feeding, and also the safe and hygienic practices, cooking practices and hygiene issues. The gender used from Helen Keller's Nurturing Connection curriculum, which looked on the gender dynamics, norms and roles, and session were also focused on the household decision making, agriculture production and nutrition. So this started in 16 and the training session was delivered over at least over a 7 months of period. The training on agriculture and nutrition BCC was delivered by sub-assistant agriculture officer and nutrition worker, while HK delivered the gender nutrition training. Sub-assistant agriculture training was monitored by sub-district level Upazila agriculture office There's an extra layer of oversights from Agriculture Policy Support Unit, IFPRI, HKI, who conduct the routine field visits to ensure the quality and accountability. Let's look at some barriers. So, male participants, ad hoc workload, and harvesting during planting season leads to absences. Also, the delivering of the high quality training initial stage was challenging. Despite this, there are several factors on enablers. So Angel actually designed a combined training which actually give a integrated it's an empowered household to gain knowledge and adopt better practice. IFPRI and Minister Department of Agriculture Extension monitored the overall implementation. However, there is a interministerial committee form which actually oversights time to time to ensure the quality. And the final enablers approach. So this how approach actually ensure collective action and understanding, this actually facilitating actually overall program research success. If actually good result, I am going to share a few, and I'd like to acknowledge all the authors of the Angel papers whose results I have used here. So so Angel treatment arms, you can see that treatment arms affect on improved agriculture production knowledge. So that included agriculture actually has impacts on improved agriculture production knowledge, but you can see impact are more on women than men. This is because women actually attended more training sessions. This slide shows the impact on the improved nutrition knowledge. For women, all the treatment arms that included nutrition have impact, but the magnitude of the impact is relatively small. This is because at the baseline level, knowledge was already high. For men, you can see the impact slightly higher. This is because baseline level knowledge was lower. This is actually dietary diversity, how we measure the household dietary diversity. It's a count variable. We actually measure the food groups in the last 24 hours, range from 0 to 12 food groups. This slide shows the treatment Angel impacts on women's and men's empowerment. In the control group, you can see that 25% women were empowered compared to the men by and for women's empowerment outcome, you can see all the treatment arms have significant impacts by 8 to 13% percentage point from control mean. And for women, there are no significant impacts except only from treatment arm that included nutrition only by 10 percentage point. So gender parity actually achieved when a woman in a household either empowered or actually achieve same empowerment score as man does, primary man does. So you can see the only treatment arm that included agriculture, nutrition, gender, and agriculture and treatment arm that include agriculture and nutrition have impact. And magnitude of the impact you can see from treatment arm agriculture, nutrition, gender linkage, 13 percentage points increase control compared to control group, and from treatment arm agriculture nutrition you can see 8 percentage point increase from the control group. I'd like to share some policy implications. So Angel actually implemented by government. This is the first and in Bangladesh, and Angel provided a proof of concept, and it has arguably contributed on inclusion of women empowerment section in the National Agriculture Policy. Also, this research success shows that integration of nutrition in the extension services has potential impact on scale up of this type of activities using the large workforce of extension. And government actually approved for national club. However, because of COVID and other global shock, it has not happened yet, but discussions are ongoing with government and and other partner. So I'd like to recap my presentation, reminding that Angel led to increased nutrition knowledge, increased agriculture production knowledge, increased production of selected non-rice crop, increased consumption of food with high nutrient values, improved household dietary diversity, increased empowerment of women and men, improved gender parity between women and men in household, and finally I would like to one message: training on agriculture, nutrition, and gender sensitization had greater impact on diet quality. Thanks for your attention.
Thanks so much. I think a very clear example of another pathway to engage with the agriculture extension work, which is generally missed when we plan for nutrition interventions through our health systems and other such systems. So thank you so much for this sharing. So let me invite the next speaker. We have Sasmita Podel, Senior Research Manager from Helen Keller International. She will be presenting on the implementation research to connect the dots for MMS in Nepal, strengthening health systems, policy engagement, and nutrition education.
Good morning, everyone. Thank you, Chair. It's my presenting on the research aimed for connecting dots for multiple micronutrient supplementation in Nepal. So I'll walk you through. It's not working. Okay. So I'll walk you through the background and the rationale for this research, following by the methodologies, study progress, next steps, and the acknowledgements. Now let's dive in. So as we all know, micronutrient deficiencies in the world and in Nepal are the major concerns for maternal and child health in Nepal because of its implication in the pregnancy outcome as well as the development challenges. Global evidence since past 2 decades has shown that multiple micronutrient supplementation has been very effective for pregnant women for improving the birth outcomes, and we have a lot and ample of and also, WHO has recommended this product WHO's essential medicine list. So following this, in 2023 in Nepal, was conducted to see the potential transition from IFA to MMS, where all the government as well as other stakeholders show the interest in transitioning from IFA to MMS. Hence, we are conducting the implementation research to evaluate and acceptability of MMS by pregnant women within the Nepal's health system. So now, within this design, we have 4 different pieces of the research. So this research is being conducted in whole 7 provinces of Nepal, and we have 4 different. So Namaste MMS trial, as you see, the first is a randomized control trial with 3 different arms, that is IFA blister as a control group, MMS blister, and MMS bottle as a intervention group. So this study is being conducted in 10 districts of Lumbini out of 12, and we have 40 health facilities per arm. So altogether, the sample for this Namaste study is 2,640 pregnant women. And the next study is the MMS demonstration study, in which we have a cohort of pregnant women from 6 other provinces. And the health facilities in these provinces are selected purposely in between 3 to 6 health facilities. And we have a sample of 600 pregnant women who are being given MMS blister. So other 2 studies are the qualitative study related to acceptability and operational feasibility. So the acceptability study focuses on the interviews and the FGDs with the pregnant women and the family members to know the factors that influence and to know the various as well for uptaking of these MMS and IFAs. However, similarly, operational feasibility, will be speaking and talking and finding the information from the ANC providers, FCSBs, and the health system care provider to see what are the operational gaps and the things that need to be done when going for the transitioning from IFA to MMS. So we have a lot of like different research questions for the individual research questions, but the major primary research question for Namaste is the adherence to 180 mms blister compared to the 180 IFF blister. So as of now in Nepal, 180 is the tablets that has been recommended for during pregnancy and 45 days for the postpartum. We have been looking also, the second is the adherence to IFA MMS bottle compared to MMS blister. So there are a lot of like secondary questions, but the methodology is like we will be following the pregnant in different time points. So the secondary questions pertaining to it is in the adherence and acceptability at 30 days point, 90 days point, 180 days point, and 225 days point. So similarly with the demonstration study, the primary question is to see the adherence of MMS after 180 days of supplementation for the pregnancy, and we'll also be looking at the acceptability of MMS after 30 days. The secondary questions for this are also similar to the Namaste trial. So we'll be looking on the adherence to MMS after 30 days, after 180 days, and 225 days. And also here, we have added a phone survey to see the validity of women's recall on the amount of MMS received versus the pill count, that is the gold standard. So now coming to the acceptability related questions. So here we are actually looking to ensure that the factors that prevent and also facilitated for the optimal adherence for the pregnant women, and also to identify what roles within the families plays as a major influential factor for the uptake of these supplements. So now for the operational feasibility, we'll be talking with the health workers and the FCSB to know their perspective on providing ANC and PNC services, especially focusing on IFA and MMS. And also with this, this will aim to find what are the storage gaps or resources that will be required, and how the best strategies can be drafted by the government to uptake this initiative. So coming to the progress so far, we have finalized the protocol, study tools has been finalized, NHRC approval has been secured, the import of MMS to the country has been completed, as well as whole the research team is on board, study has started, and we have already sensitized like all the health workers in 7 provinces, including 135 health facilities, 1,159 health workers, and 947 FCSB. So now we don't have the result of this research yet, but the progress made so far is for the Namaste MMS, we have reached to 61% of the samples are already enrolled in the study, and for the 30 days follow-up, almost 45% of women are enrolled. For the demonstration, we have 7.5% of the samples that has been enrolled in the study, and the data collection for MMS acceptability is planned for June to July 2025, with operational feasibility starting very soon from January 2025. So now coming to the main key takeaways is like, yes, Nepal government is very committed to maternal and child health, and this study designs allows for the flexible response for the contextual challenges. So the next step is like we are, so this study is also in the conjoint with a supply readiness assessment that's, that's we are undertaking, and the findings for supply readiness assessment will also, it's in the final stage being ready to disseminate, and we are also aiming to like after the finalization of this study, disseminate the findings in upcoming presentations, conferences, through publications and all these things, so which we are aiming for around mid-August 2025 in ICN or similar conferences. So with this, I'd like to acknowledge all the personnel who really supported for this. I have my co-PI here, Kenda Cunningham. I'd like to thank her, other study investigators, study participants, research staffs, trial steering committee that we have, and also government of Nepal, our donor, Ellen Crook Foundation, and the Kirk Humanitarian Fund of Bhuttal. Thank you so much.
Okay, thank you for keeping exactly the time. We hear the very good evidence from the one comprehensive research. that not only look at randomized control trial to see the impact, but also look at the demonstration, the feasibility and the acceptability, see how people are getting to that and how we can scale later on to get buy-in from community and from government. So we look forward to see the results that will coming out soon. Yeah, thank you. So I would like to introduce our next speaker, Dr. Samida Powder, I messed up, sorry. Dr. Leela Birkam Thapa, Senior Public Health Administrator, Ministry of Health and Population, Government of Nepal. And the presentation will be focused on strengthening institutional capacity for breastfeeding promotion, a case study from Nepal.
One is forward. Thank you very much, Chair. Namaste to you all. Just I'm going to share strengthening institution of capacity of the breastfeeding promotion in Nepal. There are some contents which I will go through it. The rationale and objective of the Mother and Baby Friendly Hospital initiative or case study was recently in Nepal, the institutional delivery is increasing in trend. If you see the number, 28%, and early initiation of breastfeeding and the exclusive breastfeeding is declining. Then the 2016, this study shows it really needs to further efforts to promote, protect, and the support of the breastfeeding. The government of Nepal gradually scaling up the Mother and Baby Friendly Hospital initiative to the federal hospital, provincial hospital, and up to the birthing center. This is our further plan. So also we need to integrate with the maternal or maternity care and the neonatal other cares as we are doing. So the capacity development of the health workers is important to further accelerate the breastfeeding, quality of breastfeeding services and quality of breastfeeding. So in this study, the team of the Helen Keller International and the government of Nepal nutrition section, we are collaboratively working with this study, and this was a study in one of the hospital of the one of the western region of the Nabal Parasi, West Nepal. These are the approach and methods we follow. So we do have the existing Mother and Baby Friendly Hospital initiative guideline. Initially, we are starting this Baby Friendly Hospital initiative in 1995. So in 2006, we just adding on this Baby Friendly Hospital initiative in the Mother and Baby Friendly Hospital initiative. So now we do have the guideline. So we did 2 days orientation of all the hospital staffs, medical superintendent, matron, gynae and obstetrics, all the nursing staffs and paramedics, how our BMS Act is the rules and how do we avoid the substitute of the breast milk, and what would be if you violate the rules, what would be the penalist or something like that. So we are we provide the capacity development, and after that we just make a action of the action plan. We develop the action plan within that groups. What are the gaps and challenges within that hospitals, and how we can overcome to increase the breastfeeding and to, so in that way, we also form the one of the community committee to monitoring and regular monitoring and supervision, and then they themselves, we provide them the kind of format and tools, and they just do the self evaluation, and they just plan the further action plan and for the betterment of breastfeeding. So these are the findings. The assessment, once we completion of the case study and assessment, the main significant gaps of the reveal the main significant gaps of the Mother and Baby Friendly Hospital initiative or implementation, actually for the implementation, and the privacy and practicing rooming in and skin-to-skin contact, availability of the written breastfeeding policy on their ward or somewhere. The supportive groups and the staffs, they really we need to improve in that that point. So the major reasons of gaps and lack of training, the once we do have the BMS Act in 1995, around 1995. So it's a long time. We are not accelerated. That was very passive. So since 3 years or 4 years, we are just accelerating the different activities about the sensitization. So that is the one key point to improve the breastfeeding. Breastfeeding to all the health institutions. So once we practice this, we orient the hospitals, and the initial score was 60-70%, and after that the score was it was increasing. The success factor are the comprehensive staff orientation, training. So these are the, if you talk about the significance and application, the case study which demonstrates the feasibility of the achieving higher Mother and Baby Friendly Hospital standards in a resource limited setting. Also now we are increasing the number of lactating management unit and number of lactating management services. So to do the betterment of breastfeeding and to avoid the bottle feeding in Nepal. Thank you very much for your patience.
Thank you, Dr. Lilam. This presentation gives us very good insight on explain why the early initiation of breastfeeding and breastfeeding is low in Nepal. At the DHS in Nepal, we are also surprised to see that between the 16 and the 22, early initiation of breastfeeding stay the same, but breastfeeding actually reduced from 60 to 55%. So we try to understand why, and then from presentation today, we see that the guidance is there, but we lack training, we need assessment. That's why people don't adhere to the guidance, and that is a very strong key message that we should apply to improve that. Thank you. Yeah. So I would like to introduce the next presenter, Satinarayan, sorry if I pronounce wrong, PhD Fellow in Economics in Visakhapatnam University, and you will present about child survival in India, unveiling the transformative power of healthcare and hygiene.
Good morning, all dignitaries. I'm feeling very honored to present my research study, which is entitled by Child Survival in India and Unveiling the Transformative Power of Healthcare and Hygiene. Myself, Satyanaran Kumbhakar, with my co-presenter or co-author, Professor Pinaki Das. So, as we are all aware that the fact that India takes a pride of sustaining large child population in the world, but at the same time we cannot deny the very truth that India has the highest rate of malnourished and Indian children in the world, and India has the highest number of under 5 mortality at 1.3 million in 2015. So moving forward, we estimation this objective, first objective is to examine what is the neonatal infant and under 5 mortality rates in India and understanding the current status of child survival. And the second one is to investigate the impact of healthcare and hygiene availability, quality, and utilize the child survival rate. And after that, we analyze the socioeconomic and maternal nutritional fact that significantly affect the child survival. And after that, we suggest some policy insights. So we are used basically data from National Family Health Survey, unit level data, the recent 2 round, 4th round and 5th round, which is 2015-16 and 2019-21. And here we methodologically use the logistic model regression, and formulating this healthcare index and hygiene index, we use the dimension measure. When we see the fact that child survival, we come in our mind that the 3 important indicator, which is the neonatal mortality, infant mortality, and under 5 mortality. So we easily observe the under 5 mortality as decline is 7.8%, which is significantly declined, but still the 41.9% under 5 mortality is present. That is a serious concern for our country. So, and what about the state level scenario? State level scenario is yes, these changes are happening. There is a Tripura is the highest in neonatal mortality, and followed by the Uttarakhand and Manipur, and there's a Meghalaya also there, where in case of infant mortality, as Tripura is still high, and in under 5 mortality, there is Tripura is also high. It's 10.6 percentage point, but amazingly says the decline rate is in neonatal mortality is Sikkim 15.8%. So moving forward, here we categorize 3 different quartiles. There is the high level of mortality rate, which is lie between 50% and above, and moderate are 30.1% to 50%, and the low mortality. We are easily observe there is the high mortality in 2015-16. There are the 8 states are present, but in 2019-21, it's only 3 states are remaining. So there is improving the health status. Where in the case of low under 5 mortality, there is low under 5 mortality. There is 13 states there, where in 2015-16 it was were in the 5 states. So after that, when estimation the healthcare and hygiene indexes, so we are popularly important indicator that where we find from several researchers are used. The healthcare consists with 3 important indicator like antenatal care, institutional birth, and full immunization, where in case of hygiene, which is reflected by the safe drinking water and sanitation facilities. So what is the overall scenario in India? Overall scenario in India is all our indicators are increases, where amazingly says that in sanitation facility is increases 21.7 percentage point. So these are the state level scenario, the changes between 2015-16 and 2019-21. That is somehow the more of the state are same scenario, but in Uttar Pradesh, Bihar, Uttarakhand are still remaining the lower rate of healthcare. So the similar condition for the hygiene index. And here is the density distribution measure to understand the under 5 mortality in relation to healthcare and hygiene in India. We easily observe the probability density distribution in relationship to healthcare index and hygiene on the under 5 mortality, which is in between this year. The both figure are density distribution indicating the slowing in upward and indicating the less decline in under 5 mortality due to the lower healthcare index and hygiene values in 2015-16. But whereas in 2019-21, what is the scenario? The diagram is becoming flatter due to the improving the healthcare index and the hygiene value, and slowing down the volume of the curvature indicating the greater reduction of under 5 mortality. So these are the in this conceptual framework, we estimation the econometric or logistic regression model, which how the effect with associate factor. And here we estimate the child survival. When we measuring child survival, this already I mentioned it, that the 3 year depend, okay, thank you. And the associate factor, we take 4 different domain like the maternal factor, social, ethnic, health practice, and treatment, education, and household characteristics. So when we come to the estimation model, we easily observe the healthcare and hygiene is a favorable impact for all 3 indicators, like is a significantly implies this less likely to be the higher rate of less likely to be the higher rate of under 5 mortality rates. And in case of here, the household health insurance is playing a good role to reduction the mortality rates for these factors. And here we observe that the OBC are facing the more vulnerable for mortality across these 3 factors. And after that, when we see the educational factor, the women literacy rate are playing vital role to reduce the under 5 mortality, and also find out that the under this marriage of 18, the UAM, which is implies the significant role for the higher rate of under 5 mortality. And the time is significantly implies the over time is a decline. So from this result, we come to conclusion: improving healthcare and hygiene are key and reducing the under 5 mortality. Higher healthcare and hygiene index state like the Kerala, Tamil Nadu, and demonstrate significantly lower under 5 mortality, and underscoring the role of accessibility healthcare and hygiene practice. And here the women literacy, empowerment, and decision making is a health study that influence child survival and creating a positive feedback loop for child health outcome. So when you come to the policy recommendation, target the health intervention, the prioritize, prioritize the healthcare access and high under 5 mortality state, offering subsidize the antenatal institutional birth and the full immunization to reduce disparities. And the last one, they emphasize the birth spacing and delaying the marriage age in maternal health policy and further reduce of under 5 mortality. So thank you.
Yeah, thank you so much. I think very clearly highlighting the critical link between health and hygiene, but also the importance of looking at subnational disaggregated data to see what it informs on policy recommendations. So with this, let's move to the last presentation for today's session. Jabindra Bhandari, researcher at Tribhuvan University, who's going to present on nutrition-friendly local governance in Nepal, a case study of Siraha district.
Thank you very much, co-author, co-chairs. And first of all, I would like to express my sincere gratitude and appreciation to the conference organizer for this important opportunity and being part of this process and sharing and learning opportunity. So my topic is nutrition-friendly local governance, a case study of one of the districts in Nepal. We know that in Nepal also, the the malnutrition is very much alarming still. As we can see that although there is a gradual progress in terms of declining stunting and wasting, but we need to work more to further decline it to address the problems. In terms of policy responses, we have the 16th periodic plan, which also identifies nutrition as a key development agenda. Uh, we have, Nepal multi-sector nutrition plan, third phase. Now it has just started, and that has also facilitated some sort of local level multi-sectoral nutrition interventions to support or to facilitate the communities, health workers, and the societies, which is in progress. Basically, there is a growing emphasis on the local level, how we can make nutrition governance more responsive, accountable, gender sensitive, and more empowering communities, building the resilience in the, in the context where we have the pandemics, natural disasters, and certain emergencies we are facing. This is, I would like to briefly discuss about the methods or the methodology. We have the desk review. Particularly, it was the ethnographic fieldwork, which concludes, the in-depth interviews, informal group discussions, observations, and participatory social resource mapping, and some sort of narrative analysis. I would like to highlight a few results or findings from this study. Basically, there is a participatory review and mapping of nutrition services and the socially excluded populations. I think the progress is there, but the process is a bit slow, but in progress. Areas where the MOM and SAM cases are more prevalent, particularly among poor and socially excluded groups, trying to a little bit find more on access, utilization, and other services. Other part is the, the embarking on multi-sectoral and multi-stakeholder and multi-sectoral coordination journey. Now, local governments in Nepal, they have started because there are committees for multi-sectoral nutrition and food security. So they are trying to engage the other sectors, for example, agriculture, livestock, food, health, education, water sanitation, urban development, and all this, and including community groups and civil society and other institutions also. As I mentioned, the localization of MSNP third is still in progress. Actually, it has started from phase 1, but it took a long period of time to really institutionalize the process at the local level. There is growing emphasis on inclusion, basically social inclusion, representation, and social participation of marginalized and excluded groups in different communities, in different contexts. But there is a great challenge in addressing socio-political, cultural, economic, and geographical disparities that impact on health and nutrition outcomes. This is the challenge. Basically, the nutrition-friendly local governance, which is owned and governed in the municipalities or the local governments, they are the key institutional structure to facilitate the multi-sector and multi-stakeholder activities. We find that health and nutrition narratives are changing. The way we used to look at health and nutrition, now from people's perspective, from marginalized population's perspective, how nutrition and health means to them, what embodies, the embodied narratives and embodied experiences of the health and nutrition are gradually changing. This is due to the more interactions or mobilization of female community health volunteers, civil society groups, local government officials, healthcare providers. They have a very good interactions at the local level. Perhaps this has changed the narratives and paradigm of health and nutrition. If we look at the leadership and ownership of the local governments, which is the political body, now nutrition governance as a political agenda, now the local governments, they have prioritized nutrition in their annual planning processes, in policies and strategies. They have allocated some resources for the nutrition. I would like to summarize the results and findings. So there is enhanced appreciation of the importance of nutrition for development. Second, increased local political leadership and engagement for inclusive decision making in terms of nutrition and health. There is enlarged the political space for civic engagement for particularly nutrition sensitive and nutrition specific interventions. So some implications we can draw or we can see in the inclusive nutrition governance. So all stakeholders are included in planning, implementation, evaluation processes. Local government's commitment and accountability, as I already mentioned. And another part is empowered voices of local communities who are particularly socially excluded. So the nutrition-friendly local governance provides some sort of civic as well as political space to engage those communities and people into the process where service provision is maintained. So lastly, I think there are critical needs to consider for policy perspectives in terms of mainstreaming gender equity and social inclusion, pro-poor and people-centered nutrition policies and efficient service delivery, and expanded access to quality health and nutrition services at local level. All these implications will eventually contribute to improved health and nutrition outcomes. Thank you very much.
Yeah, thank you so much. I think an excellent example of the role of local governments in trying to address multi-sector nutrition issues, and this is critical area and a level at which we want the multi-sector nutrition actions to be effective, right? So I think Nepal is taking the lead and showing the way for countries in South Asia, how multi-sector nutrition actions can be operationalized at ground level in order to achieve impact. So I would like to invite the presenters if they can come to the head table. So we have 10 minutes now where we can entertain questions. So let me prioritize questions from colleagues online. Are there any questions? Yes, please.
We have two questions from Ali Niger for the presenter 3. What about the employers to provide support to breastfeeding mothers through designating rooms for employees with under 2 children? In my area, many young age women are either teacher, nurses, LHV, and in other professions, but the maternal leave is only for 3 months. How can the child be breastfed?
Yes, please.
Thank you very much. Very important and valuable questions. In regards to maternal leave, we do have 98 days of maternal leave in our policy and law. Even though some of the organizations, all the private and other organizations, they are not providing that leaves to the mother. So now we are trying to monitoring and supervising and supervising and inform them. Recently, we inform all the entities and all the institutions. This is the mandatory leave for the women and children, for their health of women and children. So this is the steps we are now taking to implement that leaves, maternity leaves to all the women of Nepal. That's right. The one question. Is it clear to you? Or?
Yeah, I think colleague online will have noted that. Any other question online? Okay, so we'll open it up to colleagues in the room. Yeah, we have one question here and one question from behind and one there.
So Good morning, colleagues. Myself, Arpit Singh. I'm Senior Research Fellow from International Center for Research on Women's. So my first question is from Aklima. Ma'am, you have the program that you are running, the gender sensitization program. So my question is how you are segregating the gender sensitization program among the men's and women. Are you doing it separately, or you have the same integration of the program? And should I continue with the second question also? With the second author also?
Yeah,
or
so maybe there are 4 questions lined up. Maybe we'll do the 4 and then come to you depending on time, if that's okay.
Okay, that's okay.
Yeah, Naomi, I think you wanted to ask.
Thanks very much. My question was to Dr. Leela about the situation in Nepal with the promotion of the mother and baby friendly hospitals. My observation in Nepal over the last several decades is how women delivering in health facilities are getting told that they should buy formula milk by doctors, saying, oh, you haven't got milk yet, your milk hasn't come in, she can't, the baby's going to get weak, it's going to get hyperglycemic, why don't you just give some formula? And I'm seeing this repeatedly in the Kathmandu Valley. I was just wondering whether what you've been trying to do to counter that, and if there's anything that could be done to sort of control that. Thank you.
Thank you very much.
So let's take 2 more questions and then we will come to all of them. Our gentleman at the back.
Hi, good morning. This is Samarth Kashyap. I'm co-founder of DSDC, a tech company. My question number 4. We were talking about mortality of neonatal children, under 5 children. We looked into the factors of hygiene, ethnicities. One thing which I was wondering, I'm not sure if you have covered or maybe I missed it, socio-economic or financial factors, did you look into that as well, and how does that impact the, the factors of mortality? Thank you so much.
And the final question for this round, Madam, you wanted to ask.
Thank you. Really enjoyed the session. This is Sohana Shafiq from ICDDB Dhaka, Bangladesh. My question would be to the 5th presenter on the local level engagement and the governance. We know that for public health workforce and who will be delivering the nutrition services, there is lack of public health workforce in the ground level, and many times there are absenteeism and lack of human resources for health. So how do you actually utilize this local level governance, and who did you, if you provided any human resource optimization capacity building activities, and who were your target audience, and what were the drivers and the challenges or the barriers of this kind of engaging the human resource for health? That's my question. Thanks.
Right. Thank you. Maybe you would take the question.
Yeah. So I can start now. Thank you for this question. I think this is on gender component strategy, how actually we conducted or adopted in the Angel. So actually it's a 2-way integration and segregation. So segregation in terms like this, like we actually engage husbands, wives, and also mother-in-laws for gender component. Due to time limitation, I did not mention those details. So we actually form a separate group in the community, and simultaneously on the same day, same topic, all 3 groups like husbands, wives, and mothers-in-laws, they attended the training, and they actually separately, independently can get opportunity to discuss late on the gender norms and dynamics and other issues. Subsequently, on the same day, actually, we pull all the members in one group combinedly, where they can actually discuss and come to a consensus what types of gender practice, what types of gender norms and rules they are practice, whether it's harmful, whether it need to change. So regarding changing this, they need to come on a consensus in this combined group. So this is how actually we design and implement it in our Angela study. I hope this serves your answer. Thank you.
you very much for your questions. Yeah, as you know, there are the many challenges to for the milk to increase the breastfeeding or to avoid the milk substitute because of aggressive marketing and the compliance of mother and baby friendly hospital initiative and enabling workplace. So as you rightly pointed out, here is now till the date there is the issues, but the government in Nepal is now it's aggressively we are doing different sort of activities, different sort of approach and strategies to decrease or to decrease the substitute milk substitute by activation of the strict enforcement of the BMS Act, one, and other is to provide the orientation and training of the service provider, and also the strengthening the breastfeeding week, the campaign and the breastfeeding corner to each and every hospital and the other public places. So some of the activities we are doing. So government of Nepal is very much aware of that, how to decrease or how to promote the breastfeeding in the future for the betterment of mother and child.
Thank you for your asking question as a nice question. There is already I mentioned in our estimation that we include like socio-economic factor, health practice, and but here we not included the financial part. So this part actually I'll take your as a suggestion. Thank you. I think you got my okay. Thank you.
There was one more response. There were 4 questions. I don't know if we addressed all 4.
Thank you. In my perspective, I think as one of the presentation from Nepal is about the institutional capacity building, for the local governance part. Basically, local governments have limited human resources. They lack some sort of, learning resources, training, follow-ups, and some sort of facilitating processes for nutrition services at different levels. Now, local governments have the sole responsibility and they have the accountability to provide the essential healthcare services, nutrition services, other social services. The critical part is the implementation part, which is very much concerning. There is growing emphasis on dependency on local governments, because local governments are the only institution to provide services. But support from provincial governments or federal health or other social systems is very low. So in terms of the capacity for these delivering the nutrition services or other social services, it is particularly important that the healthcare workers, health institutions, as well as the government institutions and other private sectors, perhaps more engaging with the communities is critical. So I think as I mentioned, the multi-sector nutrition plan phase 3rd, and as well as Nepal government's health policy, nutrition policies, strategies, and the critical support from other partners, for example, UNICEF, there is Helen Keller International, and other key partners are supporting to provide the capacity needs and the capacity strengthening part. I think that is more critical in terms of ensuring access to the nutrition services. Thank you.
Thank you. I think we have time for 1-2 more questions.
We have one online question for anyone in the panel. Would renaming maternal leave as parental leave bring about shared responsibilities in infant care? European countries already do so.
Anyone wants to respond to that?
Yes, about the maternity leave and paternity leave. So even though the different, our Southeast Asia and other countries, we do have the different number of month. There is a variation of the maternity leave. But in Nepal, we are just drafting the BMS Act, new BMS Act. In that act, we are just trying to put the 6 month, the higher level of maternity leave, which is practicing in some of the among the other countries. So only the leave is not working as well. So the enabling environment of the hospitals, enabling environment of the family support and their family support, community support. So there it needs to be aware, or needs to be orient, there needs to be support for the mother to provide the breast milk, early initiation, exclusive, and the beyond the 2 years. So that is the point.
Right, thank you. Gender, your second question, if we have time for that, and then we will move to the rapid fire presentation.
Thank you. So my second question is to second author, Shashmita. So as the study is progressing, and you have said that MMS is demonstrating, so are you seeing the dropouts? And if yes, what are the challenges in those dropouts, the challenges or the reasons behind the dropouts? Can you explain, or you have seen that, please? Thank you.
Thank you very much for this very important question, actually. So this would be very premature, like to disclose the number, and actually, so I'm just giving what are the reasons actually being seen for the dropout. So a few cases for dropout is because of our, the Lumbini trial area. It's most of the health facilities on the Tarai, which are very near to the India border. So the trend in some of the culture is that once the women get pregnant, actually we have that in our eligibility criteria. If she will be staying there for 9 months time, but no one knows. So once after getting enrolled in the study, they are moving back to their maternal home. So that is the reason, that's the loss to follow-up case actually we are seeing in this story. And the main cases for region is sometimes the family members, they are not up for the new product, If it's usually the second pregnancy or something like that, and if a pregnant woman had taken it IFF before, then there is some family influencing factor. In the health facilities, she give the verbal consent, and the health facility workers, they give her the choice. She take it home, but while we go for the enrollment at the household, then she's not up for it. So the main reasons here we have seen is related to the family influence related thing, and very few cases related to the taste and the size. That's all. Thank you.
So at this point, we would like to thank all the presenters for fascinating presentation, and also thanks all audience for raising a very good question. And then we have very nice dialogue between the presenter and the audience. So let's give the applause to the presenter. So continue, our next section will be the presentation from Rapid Fire. In the Rapid Fire, we have a 6 presentation related to addressing the issue how to improve the child stunting and also the diet in different countries. So I would like to introduce the first presenter, Ketana Ravi Georgia, the research associate at IFPRI India. She will present the role of Grand Panchayat in ensuring intersectoral coordination for improving stunting outcome in West Bengal.
All right, starting. So what have we learned from subnational India for multisectorality to improve child stunting outcomes in India? Thank you to all of the presenters who went before me and actually spoke about how important it is for multiple partners to come together to work towards the moving parts of nutrition. Similarly, we are here to provide you with a solution about how child nutrition could actually be worked upon multisectorally, and this actually works on ground. So to begin with, from our stunting exemplars experience, we realized that multisectoral progress happens in multiple places, but it is very difficult for us to actually pinpoint a mechanism or a process by which that happens. And West Bengal, one of our stunting exemplars states, provides us with a compelling way or a case to actually tell us that not just intent, but a proper process was put into place using their CHCMI initiative, which is the Community Healthcare Management Initiative. This particular initiative has 3 key ingredients. The first one being enabling the local governance bodies to make their own decisions through capacity building across all sectors. That means enabling them to identify their own problems, allocate resources for the same, and finally make programmatic reforms at their level. The next would be to enable and empower the community and engage them so that increased ownership takes place, as well as there is an increased amount of accountability amongst them. And finally, one of the most important points is to come up with your own monitoring and evaluation system such that you can track progress with some markers that you yourself decide upon. Thus, by leveraging the existing strength of a Panchayati Raj institution that exists in India, that means a very easy way to administer in a village, along with the closeness that these governance bodies have with the community, along with a shared sense of responsibility, I would say. It's extremely possible for us to have multisectoral action intentionally. Thank you.
Yeah, thank you so much, and good luck to all the presenters to meet the 2-minute time. So another example of how we see at local level action through local governments that is being possible. So next speaker, Malay Kanti Mridha, Professor and Director, Center for NCD and Nutrition, BRAC, will be presenting on key drivers of stunting reduction in under 5s in Bangladesh, evidence from the DHS data from 2004 to 2017.
Thank you. I am Fahmida from BRAC University. I am presenting on behalf of Professor Malakanti Mridha and other co-authors. So here we will talk about the key drivers of stunting reduction in Bangladesh. So in Bangladesh, from 2004 to 2017-18, there is a huge reduction in stunting among under 5 children. So we will actually see what are the main drivers of this stunting reduction, and also we'll determine who are the major contributor as a driver for these changes. We will use Bangladesh demographic and health survey data for 5 rounds, and we analyzed data using generalized estimating equation for identifying the drivers, and also Oaxaca blinder Oaxaca decomposition analysis to estimate the relative contribution of the drivers. So we found that the drivers that actually contributed and decreased the odds of stunting are mainly child being male, then a child living in a middle or rich households or families, child living with improved sanitation, with household there improved sanitation, and also maternal height and maternal BMI, which is higher or normal compared to underweight, and maternal education and also paternal education, and longer birth interval. And the other factors are like higher number of antenatal care visited, and institutional delivery, and measles vaccinations. So these are the factors that actually decrease the odds of being stunted. So what are the key top contributor for this? These are maternal BMI, maternal education, institutional delivery, and 4 plus ANC, paternal education, and maternal height. So as stunting is a complex indicator, government and development partners should consider these multisectoral drivers to prevent and control stunting in any country like Bangladesh. Thank you.
Okay, thank you for your insight about the factor influence child stunting in Bangladesh. Yeah. Our next speaker will be Melinda Mastan, graduate research intern, Society for Nutrition Education and Health Action. She will present virtually on the association between maternal and child minimum dietary diversity in urban informal settlement in Mumbai.
Yeah, good afternoon, everyone. My name is Melinda. I'm representing this NECA organization. Yeah, next slide. India still faces malnutrition challenges, with only 23% of children under the age of 2 achieving minimum dietary diversity, which is a critical indicator for malnutrition. Mothers play a key role in child's diet, parent behavior change communication interventions, often telling mothers what to do for their children's diet, but not necessarily on their own diet. This study examined the association between maternal and child MDD in urban informal settlements in Mumbai from data collected in May this year. We used logistic regression analysis to identify factors associated with child MDD, adjusting for covariates such as children, maternal, and household characteristics. Our key finding shows that only 31% of children achieve MDD compared to 44% of mothers. There are notable differences in food groups consumption between mothers and children. Mothers tend to consume more fruits, vegetables, and flesh foods, while children consume more dairy. This shows selective feeding practices leading to gaps in dietary diversity between the two. Mothers achieving MDD, older children, and having social protection schemes were significantly associated with children achieving MDD. These findings highlight the need for obesity strategies to emphasize that children receive the full variety of family meals instead of just a subset of mother's plate. Intervention must also focus on improving maternal dietary diversity to enhance child dietary outcomes. Social protection schemes expansion and food security initiatives are crucial in providing vulnerable families better access to diverse food. To conclude, this finding emphasized the importance of addressing maternal and child diets simultaneously to improve overall dietary diversity and reduce the malnutrition prevalence in vulnerable communities in South Asia. Thank you.
Right, thank you again, highlighting the key role of working on maternal and child diets. So next speaker is Sukanya Poddar, Managing Trustee of the Committed Communities Development Trust. She's also presenting online on first 1,000 days of care to enhance maternal and infant health in urban poor slums of Bhiwandi and Malegaon in Maharashtra. So Sukanya, over to you. So Sukanya, you're muted. Yeah.
Good afternoon, everybody. I am presenting today that first 1,000 days of care and how actually at the grassroots level it's implementing and how it is impacting the outcome of health, particularly nutrition outcome in children by addressing this first 1,000 days. I will not elaborate on the first 1,000 days of care and its impact, but I will talk about the process today. So first and foremost, when we were looking at, they were all urban health posts which were high burdened, and the SAM-MAM cases were high, utilization of services was low, IMR, MMR were high. So we intervened there along with the government and the community stakeholders together. We designed the program and we intervened. So when we were designing the program, we took them into the fold and identified the problem and bucketed them. So early registration was a problem, institutional delivery was a problem, cholesterol feeding was an issue, Even immunization was very low, refusal cases were high, exclusive breastfeeding was not happening. So we wanted to see that how we address these problems here so that we can actually reduce the malnourishment in children post 2 years of age. So this was an intervention in Bhiwandi and Malegaon, as we have seen. And this is where we, first bucket was with the health system. So we realized that there was a lack of need of capacity building with the health system providers. There was also a data management issue that we needed to address. So we involved that sector first. And then the second sector, we went to the community. We realized it's a minority, religious minority group. Community influencers were very strong, and especially religious leaders. So we tried working with them along with other, community CSOs and CBOs. And we also involved the another sector, which is the corporate sector, and got the technology into the system so that we can address all the problems together. And there we successfully implemented this program and have been able to achieve, there is a significant increase in terms of, breastfeed. You can see that all the numbers, I will not repeat, wherever we have reached, we have been able to increase institutional delivery, breastfeeding, exclusive breastfeeding, colostrum feeding, and then we have used all the religious leaders to their azan in the morning or Eid or Ramzan card. Everywhere we have tried to get them into the fold, and then created wellness group with the community for sustainability. And these women are coming together to take the program ahead. So overall, the learning is very clear that if you are doing multi-sectoral, you have to get into the community, sit with the community, understand their problem, and then design the program and get them into onboarded them and transfer the ownership to them.
Thank you so.
Empowering community and transferring ownership is something that is.
Yeah, thank you so much, Sukanya. I think your point is well made and clearly another example of involving local communities and local action to address malnutrition. We move on to the next speaker, Adviti Nepal, Family Planning and Reproductive Health Advisor with Care Nepal Communities Development Trust, will be presenting on SAT, a community-driven approach to improve maternal and child health nutrition in Nepal. So Adviti, over to you.
Organizer for providing me with this opportunity. Today I'm going to present learning from a SAT tool, that is self-applied technique for quality health, and we call them as a social mapping tool, and its contribution in improving the maternal and child health nutrition in Nepal. Basically, as I have mentioned it earlier, that it is a social mapping tool that allows the community members to reflect upon their nutrition and health behaviors and provide an opportunity and platform for community members to interact with each others and establish a support group so that they can support each other for improving their status. So the tool is basically based on the four principles, that is participation, empowerment, and equity and access. So the Care Nepal firstly introduced this tool to reactivate the health mothers group in our country to foster the inclusive participation in health services. And we have already reached over the 5,000 health mothers group through various health and nutrition programs. One example for the maternal and child health nutrition contribution done by the SAT is I would like to take from the Suhara 2 project, that was the multi-sector nutrition program which was run through 2016 to 2021. Its inline evaluation showed that it increased the interaction between the community health workers and 1,000 days mothers, and it also provided the opportunity to interact with each others for the developing a support group for improving maternal and child health nutrition. And the other Cares Nepal project, nutrition project, also suggested that it has enhanced the service access and utilization, particularly among the marginalized and vulnerable community. So we have been adopting and using this tool in recent health and nutrition project as well. And one example on the sustainability and the adaptation is that the government of Nepal has adopted this SAT tool in its equity access and utilization program, which has aimed to improve the child health and maternal health in country, and it's aimed to scale up nationwide. So this is learning how the social mapping tool has improved the community participation, women engagement in health and nutrition, and as I mentioned that the Suhara 2 was implemented in 42 districts. So this is all. Thank you so much.
Thank you for providing very good example and nice conceptual framework on the tool to improve maternal child health in Nepal. Our last presentation will be Munia Afros, Research Associate, Center for NCD and Nutrition, BRAC, JPG School Public Health, BRAC University. And he will present about factors associated with stunting among children aged 0 to 59 months in South Asia, a systematic review.
From BRAC JPGSH. Here I'm talking about our study, which aimed to identify the factors associated with stunting among 0 to 59 months old children in 8 South Asian countries. We conducted a systematic literature review across PubMed, Embase, Fupas, identifying over 9,000 studies. Ultimately, after removing duplicates, title, and abstract screening and full text review, 203 studies were included in our analysis, comprising 19 multi-country studies. We categorized the factors associated with stunting into 4 domains, such as individual, parental, household, and distal factors. At the individual level, factors such as age and sex of children and IFPRI practices were most frequently explored. Among parental factors, maternal education and BMI were widely studied. Household wealth and caste were prominently for household level factors, while distal factors like geographical location and place of residence were often discussed. Less frequently reported factors included paternal BMI and occupation and seasonality. So our study highlights the shared and context-specific drivers of stunting in South Asia. Understanding the variation and similarities in factors associated with stunting among 0 to 59 months old children throughout South Asia will help create better prevention and control program to attain stunting-related SDG targets. Thank you all.
Thank you. I would like to thank you all the presenter and both of the main presenter and the rapid fire that we have very rich presentation on various factors and various issues. We all acknowledge that the undernutrition, maternal and child health issue is still like big challenge for South Asia, and we all work together on different solutions, different initiatives to improve that. Thank you.
No, absolutely. Just to echo, I think very diverse presentations across countries from South Asia, across different levels. We saw interventions at facility, at national, but even at sub-national level, and also with a range of stakeholders, including health, but also with agriculture and others. And just to re-emphasize that actions are happening across multiple sectors. They're not only possible, they are happening, and they're happening at scale, and they are demonstrating impact as well. So hope that these examples will trigger more initiatives and actions in countries in South Asia when we're trying to tackle all forms of malnutrition. And the final message for those who are looking for magic bullets to address nutrition, probably there's no magic bullet, but there's a magic mantra, which is connect the dots.
Thank you very much. Thank you everyone for your kind attention. So it's currently 1 o'clock, and I'm going to ask everyone if you'd like to go and have lunch on the 4th floor. Our next session will be starting at 1:45. And in this room, we'll be having the thematic session 2B, Natural and Built Food Environments. But you can also see the agendas posted on the doorway. So thank you very much again, and please enjoy your lunch. Appreciate your time.